So Ms. Bipasha Gupta, she pursued with MSIF for inclusion of young MS persons in the key position as it is a young disorder. She formed youth MS groups, YMSG, all over India, a concept that was followed around the world. She also participated in a number of MSIF international conferences and contributed her best to Multiple Sclerosis Society of India. She also introduced WhatsApp MS Connect group concept in the North India, which is helping MSI Delhi chapter to connect with various states in the region. She also formed a new chapter in Hyderabad. She is passionate fundraiser and is an experienced MS counselor. Now, I will request Ms. Bipasha Gupta to give an introduction of MSI and talk about World MS Day. Over to you, Ms. Gupta. You are on mute. Bipasha ji, mute and yourself. Mute yourself. Unmute yourself.
Oh, okay.
Yeah.
Thank you, Javed, and thank you, Sheila, for inviting me to give an introduction of MSSI and MSIF. Of course, it's included, and World MS Day. If I have to introduce MSSI, I cannot forego MSIF. I have to talk about it first, then only I can get to MSSI. The MS International Federation was established in 1967, a unique global network of MS organizations and organizations working for people affected by MS, volunteers, staff, and stakeholders from around the world. They established this organization so that they can bring everybody under their umbrella. The movement finally came down to 48 MS organizations joining them, and they linked themselves to many other, more than 90 MS organizations. So most of these organizations work in the similar style under the supervision of MSIF, who guide us and who tell us how to work and who put us together in the World Forum to learn from each other. MSIF is an umbrella organization. It enrolls worldwide MS organizations under its wing and then introduce them to the best practices for MS persons. They gather all the key people, the representative twice a year in one of the countries where they talk about how they are working, how each organization is working. They are given a chance to talk about their society, their people, and anything new that happens which the other people can gather and learn. All the MSIF members share a belief that the challenges in MS are worldwide and the solutions are also must be also worldwide. It is, if there are challenges, there are solutions also. They believe in that they can solve the problems. We can be more effective and efficient by sharing our experiences and speaking in one voice. Now, getting to Multiple Sclerosis Society of India, how we got attached to them. Multiple Sclerosis Society of India was established in 1985 with only 3 MS persons enrolled in that. This is Mrs. Rahmat Fazil Boy initiated that we should have a society for this multiple sclerosis, about which nobody knows, and we need to create awareness. Way back in 85, we really thought of a thing of this kind where Sheila was part of it, because her husband had MS, and Randheria and one person Sheila would be knowing, I am forgetting his name. 3 people were there. And with the idea of minimizing the effects of multiple sclerosis, both on patients and the families, by aiding assistance in coping with disease and meeting the challenges of daily living. And later on with Mrs. Rahmat Faisalbhai, she approached Mr. Tobaccowala. He also came in. He helped her. They united together along with Mr. Randheria, Mrs. Sheila Chitnis, and A.G. Joglekar and Major Sharan. These people were the pioneers of the society, and we highly appreciate them for being so, having. Today, the society has grown immensely. We are now more than 37 years old, and we have 9 chapters. We had chapters coming up and closing down, but finally we are 9 chapters now, and with more than 3,000 MS persons enrolled. We do have a lot of MS persons in who we know, that is more than 3,000 we have, but most of them do not want to register due to social stigma and all, which all of you know. Quite a few of them. In fact, after 9 chapters, we multiply our MS patient number 3,000 by 4, because we not only look after the MS persons, we look after their caretakers, their family, their spouse, their children, the parents. We advise them, we counsel them. So it is not 3,000, it is multiplied by 4 or 5. That makes it, almost 15,000, 12 to 15,000 people we are actually dealing with each chapter. So MS person is there, he has the problem, but the rest of the people also how to cope up and how to know. They are constantly asking us, and we help them. Our focus is strategic invention on behalf of all the chapters to build India-wide programs, facilitate formation of support groups under existing chapters, programmatic intervention at national level, host and participate in international medical seminars and conferences, participate in Multiple Sclerosis International Federation, MSIF meetings, participate and collaborate with external agencies to bring collective voice on a global platform in the space of multiple sclerosis. Now, what is MSSI? You all know we are a support group, totally voluntary. We do have our offices which are run by young people who are paid, but all the committee members, they are all actually really selfless. Every chapter is dedicated, and they are working day and night for MS with all their feelings, emotions, everything. Because most of our MS people our members belong to MS families. They are either MS people themselves, 1/3, MS family, 1/3, and social workers who are dedicated, who have seen MS very closely. Now coming to World MS Day. In the year 2009, at MS International Federation, the discussion went on from the year 2007-8 onwards. That time, Mrs. Sheila Chittis was the national secretary, and she was part of it. And they were discussing how to make a World MS Day so that all the MS people come on a forum and speak, and so that the authorities hear them out and they help them. In 2009. In 2009, the first World MS Day happened, and I think India also participated wholeheartedly. Every chapter did something or the other, and it was wonderful. It was highly appreciated. And during 2010, we realized it is extremely hot. 30th May is very, very hot in India, and we are unable to cope up with outdoor programs because MS people cannot take heat, as you know. So what we did is we tried changing the day, but it was already, very established all over the world. Then we thought of having a India MS Day of our own. Okay, we discussed for some time how to go about and what to do. Finally, we succeeded, and in the year 2016, we had our own India MS Day in the month of February. That is, but nevertheless, we kept participating in World MS Day, giving it a lot of importance, having a lot of programs all around, creating awareness through media, print media, and our representatives over the years, Dolly Khanna, Jyoti Ronge, Geeta Mirchandani, Shankar Subramaniam, Mamta Gupta, and now Anjali Vyas. If I missed out somebody, I am not sure, but according to me, these were our World MSD representatives. And each of them did wonderful job. Everybody, put in their wholeheartedly they worked. We remember Shankar working, we remember Geeta working, continuous meeting, and she was along with me when I was National Secretary, and she really worked hard. Jyoti Ronge also, Dolly Khanna, in her time, she was very popular and she did her bit. Shankar, and now Anjali Vyas. Of course, our expectation is quite high from Anjali Vyas. She's a youngster, she can do lots. And our theme is, this time, last 3 years, our theme has been MS Connections. And it will be called I Connect, We Connect. That's how I connected all MS people in Northern India with of each chapter so that they talk to each other, and now they are all connected. We need to connect them. We need to connect them with the doctors. We need to connect them with each other so that they are at the best possible place and get help from each other. This is all I would say about World MS Day. And this is the 14th World MS Day on the 30th of May. And I'm sure we'll be doing wonders once more, and we'll be prominently placed in the world map. Thank you so much. It's over. Over to Javed, please.
Thank you, Vipasha ji, for sharing the journey of MSI and about World MS Day. Now, I will request Dr. AK Singh. First of all, I would like to introduce him. Dr. Rakesh is a consultant interventionalist neurologist in Bombay Hospital, Breach Candy Hospital, and consultant neurologist at Shushrusha Citizen Corporation Hospital. He's MD DM neurology by qualification, and his area of interest is stroke. He has many publications in peer-reviewed journal to his credit. So I will request Dr. Singh to facilitate the entire webinar and also introduce our other two doctors. Over to you, Dr. Singh.
Good evening, everyone. As we know, we are discussing two topics today. One is urinary incontinence and urinary problems in MS, and second is early eye problem in MS. And these two talks will be given by two very prominent speakers. First speaker will be Dr. Anita Patel. Can we have her? Dr. Anita Patel is a very well-known urologist. She has her own called endoscopy clinic practices. So, in Global Hospital and Wadia Children. For her education, she did her MCA urology from KEM Hospital. For 5 years, she was working as senior urology registrar in UK. She was assistant professor at KEM Hospital for a year from 2017 to 2018. She has a special interest in urinary incontinence and neurogenic bladder. In fact, she was a panelist for Guidelines of Urology Society of India in 2019. She has been faculty in over 50 national and international conferences, and she always supports our MS program in Mumbai, especially in Shushrusha Hospital, for examining and giving expert advice to our patients. So first we'll start with Dr. Anita Patel's talk on MS and urinary symptoms. Over to Dr. Anita Patel.
Good evening, everybody. Am I audible?
Yes.
Yes, madam.
Lovely. So thank you so much, Dr. Rakesh, for that very kind introduction. And thank you, Multiple Sclerosis Society, for asking me to give this talk. I'm amazed by the amount of work that the entire society does. And I have been familiar with all their activities through last so many years. And it's always a pleasure to be involved and be associated with all your projects in any capacity that I can. Talking about urinary issues in multiple sclerosis. Why are we talking about it in a disease which affects the nervous system in the body? As we all know, it's a disease characterized by patchy loss of myelin cover on nerve fibers, both in brain and in spinal cord. And there is a higher preponderance of women as compared to men. So the disease affects multiple body functions and urination is one of them. So let's understand what is a normal and what is an abnormal urinary system. This is just a line drawing which shows the entire urinary system. The two bean-shaped structures at the top are the two kidneys, the lines leading down from the kidney down to a crescent-shaped structure at the base is the urinary bladder. The two tubes are called the ureters. When the bladder is behaving nicely, the entire family is a happy family. As against that, when the urinary bladder is not behaving well, the entire family structure gets disturbed and we start seeing various ill effects because of poor behavior of the urinary bladder. Added to that, of course, are the problems associated with inherent differences, which are natural differences between the lower urinary tract of men and women. And some of these are relevant when it comes to managing the urinary bladder in multiple sclerosis patients. So the normal bladder has two functions. One is storage and one is emptying. That means all of us can store our urine till we choose to empty the bladder. So during that period, even if we jumped, we laughed, we had severe mental stress, so on and so forth, the bladder will not empty. But yes, we will be aware that yes, the bladder is full. As soon as we wish to empty, we will be able to empty the bladder irrespective of how full the bladder may be. And the bladder will be emptied completely. So this is the normal and the natural behavior of urinary bladder. And urinary bladder, of course, is very closely connected to our nervous system. And the basic control, which happens automatically, is at the level of spinal cord. But the higher control, which is peculiar to human beings, which is why we don't pass urine anywhere on the road suddenly, like how dogs do. But we pass urine in a closed environment only after undressing and assuming a certain posture. That's unique to humans. And all of that, sorry, I'm hearing some other sound. Am I still audible? Hello?
Yes, madam.
Yeah, okay, right. So the higher center control gives us social continence. And there are certain age-induced changes also. So any urinary problems can in theory become worse as our age advances. So coming back to multiple sclerosis, what happens in MS? The most common complaint is that of urinary frequency and urgency with or without leakage. And that is seen in about 30 to 70% of patients. The second relatively less common issue is inability to empty the bladder completely. That means inability to empty it at will. And this happens in a lesser proportion, roughly 30 to 40%. Why does this happen? This happens because the bladder behaves like an independent party. It sends a signal when it is not very full. The brain is not able to process it normally. So it cannot signal the bladder to stop because those signals don't reach the bladder. So the bladder starts emptying. That means there is leakage of urine without the patient's permission. The other issue would be when the bladder wants to empty, it is unable to because the signal from the brain to empty the door of the urinary bladder doesn't reach the bladder. So either we are unable to store or we are unable to empty. This is very often associated with bowel issue. It can be, again, the two ends of the spectrum, either bowel hurry associated with soilage of clothes or spoiling the clothes, or the complete other end of the spectrum, inability to evacuate the stools completely, often requiring some digital assistance or maybe usage of enemas and suppositories. Along with that, there are other associated problems. There is a higher possibility of infection, higher possibility of stone formation if there is stasis in the urinary bladder, and higher chance of infection because there is contamination of the area around the urinary tract because of leakage of urine. However, and I want to reiterate, any serious and permanent damage to the kidney is usually not seen. So all the issues of urinary tract in multiple sclerosis patients mainly impact quality of life. What are the quality of life issues? Social life, that means the outings of these patients revolve around availability of toilets. In fact, some patients restrict their liquid intake because they know that they might get the desire to urinate and there may not be a toilet available. Some people may be wheelchair bound and then availability of a toilet with access to a wheelchair may not be there. Many patients may be on self-catheterization or may have a catheter connected to a bag, and all the, say, shopping malls or restaurants may not have a washroom which has facilities for the disabled. So the social life is the first thing to get affected. The personal life can get affected, of course, because if somebody leaks urine, he or she is going to smell of urine. Along with that, these people need to use the washroom frequently. Imagine a house in which there may be only one toilet in the entire house. And if somebody is there in the washroom and the same house has a patient with multiple sclerosis, that patient is going to really have a problem. Also, some of these patients take a very long time to complete passing urine. Again, all of these impact their personal life. This also impacts their sexual life. So there will be, of course, problems during sexual intimacy. And last but not the least is the financial damage. Think of the number of issues related to urinary tract which require a patient to spend money. It could be doctor's fees, it could be cost of catheters, cost of medication, cost of diapers, so on and so forth. So each and every aspect of life is impacted because of the bladder behavior in MS patients. What can you do if you're a patient? First thing is talk about it. You know, urinary incontinence is always a taboo subject, and we don't discuss about urinary leakage with our friends. Imagine somebody going out for a walk and telling others that, hey, I'm urinary incontinent, or hey, I'm just leaking urine. We don't discuss that. As against that, people will say, well, I underwent a bypass, I have a stent. All of this is regarded as, you know, a big halo, but the urinary system is never talked about. So the first thing is talk about it, either to your family members or both to your family and friends. If you're in employment, talk to your employer, talk to your colleagues, because some of your special needs will require that some changes be made at your workplace. Let your caregiver be fully aware about the extent of your problem, because then all the aspects of caregiving will be modified as per your individual need. And last but not the least, involve a medical practitioner, because as in every other field of medicine, urology as a science is advanced dramatically, and a lot of aspects of urinary bladder can be looked after very easily by simple appliances, medications, lifestyle changes, so on and so forth. So do seek medical help. How do we evaluate as a urologist if a patient comes to my clinic with these symptoms? So of course, I'll talk to the patient, examine the patient. This very often involves doing an internal exam either from the anus or the back passage in men or from the vagina in females. Various tests such as urine examination and a sonography will always be done in every patient. In some patients who are able to pass urine at will, we actually ask them to maintain what is called as a bladder diary. And that means on a sheet of paper, you actually make a record of the number of times you pass urine and the volume you pass each time. This, in fact, according to me, is the most valuable tool in evaluating MS patients, because this helps me decide what is the most suitable treatment. In selected patients, we do a specialized test called flowmetry. I've just shown you a picture of a flowmetry, which is in a normal person seen as a bell-shaped curve, but in, of course, MS patients, the report is different. And what is shown at the bottom is a flow meter. We use this to measure the flow pattern of the patient. In some patients, we actually need a very advanced, sophisticated test called urodynamics, in which we check the behavior of the bladder with the help of a computer. So let's assume that the urologist has seen a patient and has decided whether a particular patient either has issues with storage or issues with emptying. What are the treatment options available? The first simple thing is change in lifestyle. And that means we can alter the amount of liquid intake and the quality of liquid intake, as well as the timings. We can also alter the food habits, because some foods and some liquids are known to trigger a bladder contraction. For example, a fruit juice or a drink which is rich in tea, caffeine, or carbonated drinks, they will produce a huge amount of urine. And that may mean you have to pass urine that much more frequently. Also, time your liquid intake so that before going out, you can stop drinking any liquid for about an hour or so that the usage of toilet when you're outside can be limited. Some of the food habits, for example, some foods known to produce constipation can be avoided, because if a person suffering from MS is constipated, that has adverse effect on the urinary bladder. We insist that every patient trains the bladder to empty it at fixed interval. This is called as timed urination. That means if it is, for example, 1.5 hours since you emptied your bladder, go and visit the washroom again, so that whatever is the urine in the bladder, you will learn to empty it at will. And this goes a long way in helping or gaining control of the urination. Some patients may need special toilets, and they can be arranged depending on the individual needs, and we can involve occupational therapists in designing those toilets for you. And of course, overall increase in activity level also helps in improving the urinary control. Physiotherapy helps in the form of pelvic floor muscle training. It helps in helping the urine control, and it tells the bladder with the help of pelvic muscle contraction when it is not the right time, and it helps the patient in holding the urine. We also use medications such as bladder relaxants. They are available very freely in the market. The most fancy medication available worldwide is available in Indian market. What I have not mentioned here is a relatively new drug called mirabegron, and that's also very freely available. Most of these, the good thing is they work when they are taken once every day. They do have slight side effects such as dry mouth and constipation, of course, which can be an issue in MS patients. But once you are aware of it, we as urologists help the patient deal with the constipation also, so that the bladder is really well behaved. Diapers are available in variety of types, sizes, absorbency, and say about 10 years ago, we didn't have such good diapers available, but now every possible quality of diaper is available, though they are a little expensive, and that would mean some patients might want to use them only when they are going out. At night, a protector plastic sheet can be spread on the bed so that there is no bed wetting. Again, these are easily available. Non-slip mats can be used both by the bedside of the patient or in the washroom, because many patients may leak urine. They may not be very fast in walking to the washroom. If they start dripping urine, and if the floor is slippery, that would mean inviting a fall and a fracture. All of these can be looked after by, using non-slip mats. Barrier creams are helpful, because if somebody suffers from urinary leakage and is using a diaper, then the skin can get affected, and a barrier cream prevents the bad effects of urinary soakage on the skin. Those who struggle to empty their bladder, there are catheters available which the patient can use himself or herself, and we have a team of nurses who train our patients so that the patient puts a catheter every few hours to empty the bladder. This avoids usage of having a tube connected to the bladder all the time with a bag connected to it, which can be a nuisance. In those who suffer from antibiotics, of course, some of them may need hospitalization and proper antibiotic usage. So in a nutshell, we want the patient to be educated, the family members to be educated, so that every aspect of their urination is looked after. These are some of the photographs. This is a standard adult diaper. All of us are familiar with it. Nowadays, we have pull-ups available where there is no sticky tape involved. They're far more easy for the patient to use. These are the catheters which are used for intermittent catheterization. The caregivers can use gloves. Patients may or may not want to use the glove. And simple lubricating and local anesthetic jelly, as well as an antiseptic solution, is all that is required. The tube doesn't have to be changed all the time. I know several patients who use the same tube repeatedly by simply keeping the tube clean. And in our urological language, we call it clean intermittent self-catheterization. All of these are very, very easily available. So in the end, I wish to emphasize that just because you have bladder-related issues because of multiple sclerosis, you don't have to, isolate yourself from the rest of the world. There is a lot that can be done. Talk about it to your family, talk about it to your caregivers. And I'm sure if we as urologists come in the picture, we will be able to help you a lot. I wish to again thank the Multiple Sclerosis Society for asking me to speak about this very embarrassing issue suffered by all multiple sclerosis patients. Thank you so much.
Thank you, madam, for beautiful, simplified explanation of urinary system and problem in patient MS. It was really one of the most simplified and beautiful version I have ever seen, ma'am. Thank you for that. We'll be taking all the questions and asking madam her expert opinion after the second talk in a question and answer session. So anyone if want to ask any questions or have any problems, they can type on chat box. We will be obviously discussing with madam after the second talk. So after the first talk, we come to our second talk. This will be given by Dr. Priyanka Kashelkar. Can we have a slide, please? Dr. Priyanka Kashelkar has completed her DNB from Lakshmi Charitable Trust, which is one of the very prominent hospital and teaching hospital for ophthalmology. In fact, recently she received Golden Hand Surgical Award for Best Resident in Maharashtra and Goa. Congratulations to her for this award. She is already an expert in performing many independent cataract surgeries. At present, she is pursuing her fellowship in phacoemulsion and refractive surgery under Dr. Suhas Haldipkar. She has published many articles in national and international journals. She has presented many free papers in state and national conferences. Today, she will be discussing about MS and how to see it early. Over to Dr. Priyanka.
Good evening, everyone. I would like to thank Multiple Sclerosis Society of India for giving me an opportunity to talk to this wonderful audience and enlighten them about the eye issues that multiple sclerosis patients face. I was happy to see the work that Multiple Sclerosis Society of India has done and would love to associate with them in the future and help in whatever little way possible. So the topic is multiple sclerosis, how to see it early. As we all know, multiple sclerosis is an inflammatory, autoimmune, and degenerative disease of the central nervous system. It is characterized by presence of autoantibodies to myelin antigens in the cerebrospinal fluid. As ma'am also mentioned, females are more affected than males, and most commonly young people are affected in the age group of 15 to 40 years. It is important to study this disease because it has immensely variable signs and symptoms and affects all the systems of the body. Coming to pathophysiology of multiple sclerosis as a whole, the cause of multiple sclerosis is unknown. However, theories suggest that there is a genetic component as well as an environmental factor that comes into play. To understand what happens in multiple sclerosis, it is important to understand what the normal central nervous system is like. So in the central nervous system, there are cells called oligodendrocytes, which coat the nerve fibers with myelin sheath. The coating has small gaps in between, which are nodes of Ranvier. The myelin sheath and the nodes of Ranvier help in fast conduction of impulses in the central nervous system. Normally, the inflammatory cells of the body, which are the WBCs, macrophages, etc., they are in the blood vessels and do not leak out in the brain. This forms the blood-brain barrier, but it is hypothesized that in multiple sclerosis, probably secondary to a viral infection, these cells leak out of the blood vessels into the central nervous system. The cells, predominantly macrophages, T cells and B cells, which are the inflammatory cells of the body, then release chemicals and cause further aggregation of cells. These cells then release chemicals which attack the myelin sheath and damage it. The damage to the myelin sheath causes demyelination, which is responsible for most of the symptoms of multiple sclerosis. The symptoms of multiple sclerosis are mainly weakness in an arm or leg, numbness, tingling, and pain. It can be balance problems and a lack of coordination, fatigue, cognitive impairment, and last but not the least, blurred or double vision. The patients initially come with initial series of recurrences, after which there are remissions. However, there is progressive and worsening disability. The disability is continuously progressive from the onset of the disease. If you see the symptoms on increasing disability versus time, multiple sclerosis can broadly be classified into 4 types. Relapsing and remitting type, which is there are acute attacks of symptoms, which then go back, the patient almost goes back to baseline and is asymptomatic between these attacks. They can be progressive relapsing, in which there are acute attacks, but between the attacks, the patient does not go back to normal and also experiences some form of residual disability. They can be secondary progressive, where initially attacks are present and the patient comes back to baseline, but later on there is progression of symptoms and progressive disability. Or can be primary progressive, where right from the onset, the symptoms and disability go on increasing. Majority of the patients are of the relapsing remitting type, and the attacks are often related to the eye. A few patients are a primary progressive type of multiple sclerosis. Newer theories suggest, however, that this is all a part of a continuum, wherein initially the patient is subclinical, followed by single events, then progressing to relapsing remitting type, and then progressing to secondary progressive type of disease. And as can be seen from this graph, the pink part shows that the increasing the disability goes on increasing as the disease progresses. Coming to multiple sclerosis and ophthalmology, multiple sclerosis often presents with ocular manifestations secondary to inflammatory demyelination of the visual pathway. Majority of the patients experience at least one episode of ocular involvement in the entire course of their disease. Ophthalmic symptoms can often be the only and or presenting symptom of the patient, and in these cases, they are known as clinically isolated syndromes. They can also lead to temporary or permanent vision loss, which in itself is a cause for great disability to the patients and their independence. Hence, a knowledge of these is essential for the early detection and better prognosis of the disease. These patients often come to the OPD with eye pain, diminished visual acuity, or blind spots or scotomas, a blurring of vision, a jerky appearance of objects, or double vision. Now, multiple sclerosis can either affect the afferent pathway of the eye or the efferent pathway. The afferent pathway is when light goes into the eye, it passes through the retina from the optic nerve into the brain. If multiple sclerosis is affecting the optic nerve near the retina, it causes something called optic neuritis. Whereas if it affects the optic nerve distal or closer to the brain, it can cause visual field defects or blind spots, which are also called scotomas. They can be in one eye or both eyes, depending on where the disease is affecting along this tract. It can also affect the efferent pathway of the eye, which is the nerves coming from the brain to the eye, which are responsible for movements of the eye. Naturally, a disease that is affecting this will cause ocular misalignment, double vision, or abnormal eye movement such as nystagmus. Coming to afferent pathway pathologies, which is optic neuritis, it is of two types: papillitis when it affects closer to the retina, and retrobulbar neuritis when it affects distal to the retina towards the brain. So optic neuritis can be one of the first clinical manifestations of multiple sclerosis in approximately 20% of the cases. In 30 to 70% of the patients, multiple sclerosis, they will develop optic neuritis during the course of their disease. It most often involves only one eye at a time and may involve the other eye later in time. It can be acute, it can happen recurrently, or it can be chronic. Now, what are the symptoms that the patient will feel? Pain on eye movement is something that is noticed by majority of the patients. There is a disturbance in color vision. So the picture on the left is something a normal person sees. And if the patient is suffering from optic neuritis, the image on the right is how he will see the image. There can be a blind spot, which is again seen by the image on the right compared to a normal image on the left. There can be flashes of light, which are also called phosphenes, and Uthoff's phenomena, which is a general worsening of general symptoms with rise in body temperature, which can be due to fever or a hot, warm bath. When the patient comes to the ophthalmologist, in 35% of cases, there is a swelling of the optic nerve head, which is seen on the image on the right as compared to the normal optic disc on the left. This is to say that 75% of the patients will have a normal optic disc even during the optic neuritis attack. So how do you detect this early? It is done with an ophthalmological examination. What we will be checking is your visual acuity. The loss of vision is sudden onset and worsens over hours or days. It may be mild in certain cases or it can be profound in others. And there is an improvement in the vision after each episode. Color vision is affected and red desaturation, that is red color loss, is much more as compared to the other colors. Contrast sensitivity is also decreased. The image on the left is something a normal person sees, and the image on the right is how the reduced contrast sensitivity is visible to the patient. This helps in detection of silent lesions of the visual pathway. Visual fields, which are tested with perimetry, can also be performed. This is how a normal visual field perimetry looks. 100% of the patients of the affected eyes and 69% up to 70% of the fellow eyes show visual field abnormalities. Most often the visual loss is diffuse, however, in certain patients. So the black portion that you see is the part that the patient cannot see. And this is how it appears on a perimetry. Optical coherence tomography is another test that we perform. In acute phases, this test is performed to check for the retinal nerve fiber thickness, that is the nerves in the retina. We check the thickness and the health of the nerves. So during acute attack, as can be seen in the picture, the colorless portions are the parts that are increased in thickness in the acute episode, and the green part is which is normal. After 2 weeks, you can still see that the thickness is going on increasing. Whereas progressively after the attack subsides at 6 weeks and at 3 months, you can see the red and yellow portions, which suggest thinning of the retinal nerve fiber layer. Whereas in retrobulbar neuritis, during acute attack, there is no change in the nerve fiber thickness. However, there is progressive thinning over time. Visually evoked potentials. So this is a test which is performed by flashing a light into the patient's eye and checking the response in the brain through electrodes that are placed over the head. This is typically not performed unless the case is a mild case of optic neuritis or if we suspect subclinical optic nerve damage. It is useful in capturing effects of prior demyelinating injury, which means that if the patient has suffered from optic neuritis sometime earlier during the course of their disease, we can also check for it with a visually evoked potential. In this, we check for increased latency and reduced amplitude. So what this means is that in the right eye, when the light was shone, an impulse or a waveform was obtained 111 milliseconds after it. Whereas in the left eye, the impulse was obtained 134 milliseconds after the light was shone. Also, the waveform or the height of the wave in the left eye is much lesser than that in the right eye. So both of these findings suggest that the left eye has been affected. Before coming to a diagnosis of optic neuritis, we rule out certain other causes such as ischemic, which is due to reduced blood supply, compressive lesions, infections such as tuberculosis, uveitis, which is the inflammation of the eye, any toxic or nutritional causes such as due to tobacco consumption or alcohol consumption. It is also important to remember that not every patient who has an episode of optic neuritis goes on to develop multiple sclerosis. The 10-year risk of developing clinically definite MS following a single episode of optic neuritis was 38%. What this essentially means that if there is a single episode of optic neuritis, your 10-year risk of developing multiple sclerosis is 38%. This risk increases to 40% at a 12-year period and to 60% at 40 years. The strongest predictor of multiple sclerosis in the there was a trial, optic neuritis treatment trial. And in this trial, it was found that the presence of brain lesions on MRI at the time of episode of optic neuritis was highly predictive of the future development of multiple sclerosis. So patients who had at least one brain lesion on MRI at the time of the episode had 56% risk of developing multiple sclerosis, whereas patients who had no brain lesions had only 22% risk. So this goes on to say that if there is an episode of optic neuritis, it is essential to evaluate it so that we can understand the risk of development of multiple sclerosis in the future. Other pathologies how multiple sclerosis affects the afferent system are uveitis, which is inflammation of the different coats of the eye. This happens 10 times more commonly in patients with multiple sclerosis than the general population. However, the incidence of this even in multiple sclerosis patients is only 1 to 2%. In uveitis, the patient has blurred vision, floaters, which is a mosquito-like thing moving in the visual field, photophobia, which is a sensitivity to light, pain, or redness of the eyes. As I explained earlier, visual field defects, which is photomas or blind spots, may be present due to affection of the visual pathway. Fingolimod, which is a disease-modifying agent used in multiple sclerosis patients, sometimes is associated with macular edema. Macula is the central part of the retina, which is responsible for 90% of our fine vision. And fingolimod may cause swelling of that part of the retina, which is obviously associated with a drop in vision. The chances of this happening are more in diabetics and in patients with history of uveitis. On the right is an imaging, optical coherence tomography imaging of a patient with macular edema. The treatment is obviously to stop this drug and start steroids. Alemtuzumab associated thyroid orbitopathy can also occur. This presents with a staring look, kind of a picture as seen in the picture on the right. There can also be natalizumab associated progressive multifocal leukoencephalopathy, in which patients present with cognitive, motor, and language deficits. Now, coming to the efferent pathway, as I mentioned before, efferent pathway is responsible for movements of the eye. So there can be ocular misalignment or diplopia, which can be at rest when the multiple sclerosis is affecting a particular nerve that is supplying a particular muscle of the eye, or it can be in a particular gaze. So internuclear ophthalmoplegia is one such disorder. In this, there is horizontal gaze abnormality characterized by impaired adduction of the involved eye, often associated with nystagmus of the contralateral abducting eye. This occurs when the lesion is in the median longitudinal fasciculus of the brainstem and is most commonly bilateral. What this means is, as you can see in the video, when the patient looks to the right, there is proper movement of the eyes. But when you look to the left, the right eye is not moving towards the nose. That is, the adduction of the right eye is absent. It is seen in 15 to 38% of patients with multiple sclerosis. But the good news is that 62% of patients suffer from... I think there is some disturbance. Am I audible?
You continue, don't.
Okay. Okay. So 62% of patients suffering from this disease have a complete recovery. There can also be abnormal eye movements, which is nystagmus. Nystagmus, as can be seen here, is to and fro repetitive movement of the eye. This is again due to involvement of the brainstem, as the brainstem is a neural integrator. It basically functions like a CPU, where it stabilizes the images on the retina when we are in movement. There can also be oscillopsia, which is that the patient feels that the world is moving. Diagnosis of multiple sclerosis is by McDonald's criteria, which is clinical and radiological. MRI plays an important diagnostic modality in this. MRI findings in the cerebrum can be in the form of Dawson's fingers. In the spinal cord can be cigar-like lesions, or in optic neuritis lesions. Optic nerve lesions in optic neuritis, up to 95 to 100% of optic nerve lesions are picked up on gadolinium enhanced T1 weighted MRIs. And as I had mentioned before, this is very important to predict the chances of developing multiple sclerosis as well as the progression. Optical coherence tomography, as mentioned before, the serial imaging with this is useful for comparing the episodes and monitoring disease progression. Systemic investigations like blood tests, chest X-ray, etc. can be done to rule out other causes. Lumbar puncture can be done, and oligoclonal bands and intrathecal immunoglobulin Gs are present in this. This is a very technical thing, but I am sure that most of the multiple sclerosis patients are aware of lumbar puncture and these findings. Coming to treatment of optic neuritis, it is essential that if you are suffering from any of these symptoms, you must consult with an ophthalmologist or your treating physician, because the treatment of optic neuritis is by intravenous steroids for 3 days, followed by oral steroids for 11 days. Steroid use has been shown to have a modest effect on the speed of recovery from an acute attack. Interferon beta-1 alpha is used in clinically isolated syndrome patients. It has shown that in these patients who have evidence of silent lesions on brain MRI have benefited significantly from this treatment as compared with placebo, that is, as compared with a control in a lot of studies. The treatment of multiple sclerosis is often that most of the attacks are self-limited. The patient has to repair damage and restore function. Patient has to follow balanced diet and good exercise. In addition to this, disease-modifying agents are present in injectable infusion and oral forms. Along with the symptoms of the disease, allied manifestations such as mobility, spasticity, pain, and bladder issues, which are present in progressive MS, also are dealt with. These are some of the disease-modifying agents that we use. They are important because they reduce the frequency of exacerbations, which are the optic neuritis that you see, and they slow the rate of appearance of new white matter lesions, thereby controlling the symptoms and attacks. To summarize, ocular findings may be the initial manifestations of multiple sclerosis and may predict additional demyelinating events. Visual disability has a significant impact on the quality of life of the patients and their rehabilitation. Not every patient of optic neuritis develops multiple sclerosis. However, there is an increased risk of development and progression of the disease with every attack. Recognizing these syndromes and signs will help the clinicians to properly evaluate the patient, formulate an appropriate differential, discuss the prognosis with the patient, and develop an effective therapeutic plan. Serial investigations help to monitor the progression of the disease, and eye care specialists can play an important role in the multidisciplinary team approach required to oversee the care of the individuals. Thank you.
Thank you, Dr. Priyanka, for perfect videos and images, really nice images and videos to understand the MS disease and especially eye symptoms. Those images telling us how a MS patient sees were really wonderful. Thank you, Priyanka. We're asking you a few questions in the question and answer sessions again.
Sure, sir.
So now we are open to question and answer sessions. Anyone want to ask any questions, you can write on the chat box. Our experts will try to answer those questions. So by the time some question comes, Dr. Anita, already some message you have received. about?
Yes, Dr. Rakesh, there have been a few questions. One very simple question was, how much liquid do we need to drink? That's always a question difficult to answer because all the international publications, magazines, everywhere they mention drink a lot of water, and nobody puts a figure on what is a lot of water. So as a result, I have several patients who spend half their day in the washroom because they think that 5 and 7 and 8 liters per day is actually the correct liquid. The correct answer would be about 1.5 to 2 liters in 24 hours, which is the total liquid intake. That would mean it includes every liquid such as tea, coffee, juice, buttermilk, very light dal, as well as plain simple water. We are a tropical country, and as a rule, many of us sweat a lot more compared to our colleagues or friends from the West. And as a result, our liquid intake needs to be a little higher. So the golden rule is about 6 to 7 glasses in a day is good enough. The patients with MS can have infection, and one of the remedy for infection is drinking a lot of water. But if you drink a lot of water, there is a risk of having to go frequently. So your urinary incontinence can get aggravated. So one has to do the tightrope walk. It's a balancing act. So maybe a combination of keeping the urine alkaline, because the bacteria thrive in an acidic environment. So all the measures to keep the urine alkaline, many of us are familiar with good old Cital liquid or citro soda. There's so many preparations in the market, or fresh lime with soda, nice homemade remedy. All of these change the pH of urine, and hence that is, that makes the urine hostile to bacteria. And so that is a part and parcel of treating UTI. Another question was, how can we address the problem of constipation? So constipation in MS happens because just the way urinary bladder and the brain don't communicate, the same thing happens to the bowel. So when the motion may be full in the bowel, the door of the bowel may not open. Or when the bowels are not ready, the door might open suddenly. So both the two ends of the spectrum, constipation and diarrhea or soilage, can happen. As regards constipation, having a good quality diet, high in fiber. Now, what is high in fiber in Indian scenario? So high in fiber, a good vegetarian diet, having lots of vegetables in whichever form you eat. Eating a lot of salads is not really the answer, because our standard Indian plate doesn't have lots of salads, but we have lots of cooked vegetables. And we eat jowar and bajra, which are very rich sources of fiber. And the tropical fruits very freely available to Indian patients. One is banana and one is papaya. And both of these are perfect remedies for improving fiber content. And you don't need a bowl of fancy salad leaves to add fiber to your diet. That's okay for Western diet, which is predominantly non-vegetarian and very, very, very poor in fiber content in general. As regards the actual remedy to evacuate the motion, either a fiber supplement apart from the dietary fiber. So these supplements are isabgol, or sometimes a laxative, multiple products available in the market. So simple lactulose or liquid paraffin, or something which is commonly known in our country by the name cremafin. As a rule, we don't take trade names in our talks, but cremafin is something that is associated in everybody's mind with correct remedy of constipation. So 2 teaspoons of any appropriate laxative at bedtime can help. But what can also help is using a suppository every alternate day, because the problem is mainly at the lower end. And, filling the rectum with a lot of stools, but the door, that is the anal opening, not opening, is the issue in many patients with MS. So inserting a suppository is all that is required. Enema looks good on paper, but is very messy for MS patient. And we want our patients to be independent. And taking an enema for a disabled person is not that easy. That means we are making that person more and more dependent. And the entire emphasis should be on making them independent. So a suppository, and a commonly available suppository is either a glycerin suppository or even the Dulcolax suppository. Both these are excellent remedy for constipation. And the third question was, how do we treat repeated urinary tract infections? Somebody used the word chronic UTI. Now that is not the word used in urology ever. We've stopped using that word several years ago, and we call it recurrent UTI. That means urinary infections which happen repeatedly. So one remedy for MS patients is, of course, to ensure that the local area is not soiled with urine or with stools. That means perfect local hygiene, timely change of diaper in those who are wearing a diaper, using a clean washroom, and those who have an established urinary infection, be guided by the antibiotic that whoever is the doctor who's treating you, it could be a family physician, a gynecologist, a neurophysician, or a urologist, but appropriate use of antibiotics in correct dosages is all that is required. Some patients believe that every MS symptom is due to UTI, and that's a myth. Every patient doesn't have UTI, but they do have frequency, urgency, irritation, even in the absence of UTI. So antibiotics is not an answer. In fact, avoiding too many antibiotics should be the mantra, because we call it antibiotic abuse rather than use. So don't use antibiotics unless your doctor has specifically prescribed them. Follow clean habits, keep the urine alkaline, drink enough water, and make sure that the diapers are changed, etc. And I'm sure we'll be able to manage the UTI well. These were the three questions which I could easily see in the chat box. Ek Hitesh Patel karine che, કેમ છો પટેલ સાહેબ? આ બધું વેબિનાર ગુજરાતીમાં નથી, પણ તમારા ક્વેશ્ચન જો યુરિનરી લીકેજ માટે હોય તો ઘણા બધા ટેબ્લેટ્સ અવેલેબલ છે. ડાયપર્સ માર્કેટમાં બહુ સારા ક્વોલિટીના અવેલેબલ છે, અને સેલ્ફ કેથેટરાઇઝેશન કરવું હોય તો જે સિમ્પલ ટ્યુબ્સ આપણા પેશન્ટ વાપરીએ છીએ, they are also not expensive. આ ટ્યુબ્સની પ્રાઇસ રફલી હોલસેલ માર્કેટમાં 15 રૂપિયા પર ટ્યુબ પડે છે. ડાયપર્સ પણ કરેક્ટ હોલસેલર પાસેથી આપણે લીધા તો ઘણા સસ્તા પ્રાઇસમાં આપણને મળે છે. I hope I've answered the query. Thank you so much.
Madam, how to prevent recurrent UTIs? Same, the answer.
Yeah, so that is the same answer that I was giving. Follow all the hygienic precautions, the diapers and everything that I've already mentioned. So that is for prevention. Once UTI is established, we do need a culture report. We're usually guided by the culture report, and some patients who are neither in a diaper nor are they catheterizing but are still suffering from recurrent UTI, they must have a sonography to confirm that there is no other cause, such as any calculus or a kidney stone, for example. Also, even though you may be having multiple sclerosis, you could also be having diabetes. So if you are having repeated infections, make sure your blood report is checked for diabetes. And once all of this is looked into, if it is just plain simple recurrent urinary tract infection, some patients need prolonged prophylactic antibiotics. And the most commonly used antibiotics for that is, one is nitrofurantoin, very easily available in the market. And the second one is trimethoprim, again, very easily available in the market. And the patients are advised to stay on a maintenance dose of these medications for as long as 6 months or up to a year also. Both of these are safe, provided they're used under medical supervision. That's it really. What is considered as high level of bacteria in UTI? So there's nothing like high level of bacteria. Normal urine will have some bacteria, often in a female patient as a contaminant. But when we do a culture test, we actually have a term called as significant colony count. And when we say significant colony count, that means a sample which is cultured in the laboratory has at least 1 lakh or above colonies of that particular bacteria. That is a significant colony count. Any other colony count or some unusual organism on the culture can be due to contamination. So it's best that the treating urologist interprets the culture report correctly.
So in short, to prevent recurrent UTI, we should investigate why it is recurrent. Sometimes
Absolutely.
it is incomplete evacuation or incomplete treatment, as madam said. So better to visit a appropriate person and see for the cause and then go ahead. Madam, someone has asked about the fungal infection and the UTI. Did you?
So fungal infection usually is a contaminant. It's not very common to have fungus in the urinary bladder. So check if you're a diabetic. If it's a female patient, then the fungal infection is not actually coming from the bladder, but a urine sample which flows over the vaginal area in a woman because of the different anatomy in a woman. The fungus gets collected on the way and the laboratory reports it as fungus in the urine. So in that case, we as urologists actually collect the sample with a catheter from the bladder to confirm that the fungus is actually not in the bladder, but it's because of sample collection error. So fungus in the urine is not very common. Having said that, if there is indeed fungus in the urine, then you of course need a specialist who will investigate and find out why there is fungus in the bladder. And that topic is beyond the purview of a common man. But needless to say, don't self-treat any fungus. It needs a lot of active treatment from the urologist.
So you should rule out diabetes whenever you have a fungal infection.
Always. As I said, in a diabetic and in a female, these are the two groups. And men who may not have been circumcised, so their foreskin may be tight, and that skin can actually harbor a lot of various types of microorganisms, and fungus is of course one of them. So diabetes and diabetes and diabetes. Check that if you have fungus in the urine or if you have recurrent urinary infection. MS, as a rule, may not be the only cause.
And many times when MS patients are on immunosuppressants, those are one of the factors where it can be.
And immunosuppressants, and if they're having to use a catheter, that's not a very nice combination. Then this is the group which may benefit by periodic bladder washes. And we actually teach the patient how to give it himself or herself if the patient is dexterous enough to be able to do that, or we teach the caregiver how to do that. And some patients need that very regularly, as often as once a week. And that can be a therapy.
Dr. Priya, someone is worried about steroid and optic neuritis. So,
yes, sir. The thing is that when you have an acute attack of optic neuritis, the nerves, as I mentioned, are under attack, and to treat them, we do have to give intravenous steroids followed by oral steroids. And yes, there is some amount of side effects that may occur on other organs, but it is essential to treat this acute attack and reduce the symptoms or the length of the symptoms and help the patient, because if optic neuritis is the only symptom, then also the patient has a lot of disability, and often optic neuritis can be associated with other symptoms of multiple sclerosis that occur during this acute attack, in which case also steroids are going to greatly help the patient. Also, the dose is monitored and the side effects can also be monitored and in some cases treated, but it is essential to treat the acute attack, because once the attack has gone away and the optic nerve damage has occurred, it is very difficult to get that vision back, because nerve injury, as we know, is not very likely to improve. So there is another question which a patient has asked me, that he had an attack of retrobulbar neuritis in 2001, and after which his vision has decreased. Further explaining what I just said, so if the loss of vision is during an acute attack, it is likely that the patient the vision comes back to normal once the acute attack has passed and the patient has returned to baseline. But if the vision has been consistently the same for a long period of time, that is quite likely that the baseline has reset for the patient, and now this vision is the baseline of the patient. However, it is important for the patient to keep checking if the vision has deteriorated beyond this and if he's getting any new symptoms, because that can be something that we can treat and monitor so that the progression of the disease can be halted by either steroids or disease modifying agents.
So in short, whenever we start steroid, we always see the side effect profile, like checking diabetes, blood pressure if patient has. We also check for many of these patients are prone for fractures. So osteoporosis and appropriate treatment like calcium supplement, vitamin D, or if something is required, we always give. Dr. Priyanka, someone has asked about the diplopia and MS and how to treat them. Can you elaborate something on that?
Yes, so diplopia is basically double vision. So it can occur, as I explained, when the patient is looking straight or at rest, or it can occur in any gaze. So depending on when it is occurring, that indicates where the damage has occurred. So if it is occurring at rest, when the patient is looking straight, it is likely that one particular nerve is affected. So we can, of course, if it is an acute attack, we can give steroids and reduce the problem. If it is something that has been the baseline, as I said, of the patient, then there are squint surgeries that can be done. There are prisms that can be given to relieve the diplopia. We can do taping of the spectacles to avoid diplopia, and the patient basically sees only from the good eye, or the eye that is seeing straight. These are methods that can be adopted if the disability is a baseline disability. If the disability is something that is occurring during an attack, then similarly we will be giving steroids to reduce the diplopia.
Yeah, so in short, if diplopia is there, we always try to find out the cause. If it is
Yes.
like relapse, we give steroid. And if the diplopia persists even after the treatment up to maybe 3 or more months, then we go for a treatment of diplopia, which includes glasses, surgeries, and some corrective measures by ophthalmologist.
Yes.
Yeah. Madam, again, a few questions on definition of recurrent UTI. Someone want to know when we will call it a recurrent UTI, or
So it sounds more like a urology program. So recurrent UTI by definition is when a person has had more than 2 episodes in 6 months or more than 3 episodes in 1 year. The causative bacteria or the causative organism can be the same, or one can get new infection more than 3 times in a year. All of these qualify as recurrent urinary tract infections. And we've already elaborated on the treatment, so I don't have to go over that again. Those are the only new questions, I think. What are the, is the bladder problem a side effect of DMT and I'm taking Plegridy? Sorry, could you just enlighten me what is Plegridy?
Ma'am, it is a long-acting interferons which are giving injectable. Actually, it is not side effect of the drug per se. It is the activity of the MS which is going on, or is the baseline problem going on. Sometimes when we start the medicine, patient may become more anxious and few generalized side effects can be there, but it's not a specific side effect for the drug per se, I would say. Priyanka, what about single episode of optic neuritis? Always a topic of discussion. If a patient has a, say, only optic neuritis, that is loss of vision in one eye, how often they should be monitored, and is there any protocol?
So the thing is that, as I said, doing an MRI at the time of optic neuritis greatly helps us in getting information whether this patient has a likelihood of progressing to multiple sclerosis. Also, if the patient after the attack has happened has noticed that there is some residual disability, we can do certain tests like visually evoked potential and OCT, or optical coherence tomography, to find out if the visual symptoms that the patient was experiencing were indeed optic neuritis. And along with the rest of the history and patient profile, if we conduct investigations and do diagnose that there is multiple sclerosis, then it can be treated. Single episode of optic neuritis per se does not have high probability of progressing to multiple sclerosis, but yes, we do have to be vigilant and keep monitoring the patient for any future symptoms that the patient may experience.
So in short,
Dr. Rakesh, if I may ask a question. Dr.
Yes.
Priyanka, what about subacute optic, the small, which is clinically sometimes, it's misdiagnosed with MS. So Could you tell us a little bit about that?
So multiple sclerosis is not a very common disease if you look at it as a general ophthalmologic OPD. So if a patient presents with blurring of vision or a central scotoma, multiple sclerosis is not something which will be on top of our list. So usually if a clinician has come to a diagnosis of multiple sclerosis, I'm sure they have subjected the patient to the necessary investigations to rule out more common pathologies that may be causing it, such as diabetic retinopathy, age-related macular degeneration, and uveitis, or it occurring because of tuberculosis, and certain other things that come in much higher in the diagnosis. If multiple sclerosis is wrongly diagnosed, there are other investigations. It is not a single investigation that related to the eye. I'm saying it's not a single investigation that will point to a diagnosis of multiple sclerosis, but sort of data from each investigation that we will club together along with the systemic history and investigations that the patient undergoes, and only after a comprehensive evaluation will we diagnose it as multiple sclerosis.
Thank you, Priya.
Yeah, single most important investigation whenever we have optic neuritis or orbital complaints that patient has MS or not is MRI. If the MRI brain is normal, the chances of him developing MS is really less.
Yes.
So as she said, usually the protocol is we repeat a MRI at the end of the 6 months and 2 years. If 6 months and 2 years is normal, then chances are much less than as and when symptoms come.
Yes.
So even if we have an episode of optic neuritis, we should follow the patient closely, not just tell them it is over and it cannot come back.
Yes, sir. As I had shown the slide which showed a continuum of multiple sclerosis. So at the top, it showed the clinical events that were occurring, and the bottommost part showed the MRI events that were occurring. So even if the patient does have optic neuritis and does have a lesion of multiple on MRI during the attack, we can produce serial investigations and on MRI and find out if multiple demyelinating events are occurring, which are at different times, and then that does help us in making a diagnosis.
Dr. Rakesh, how often we are a support group and people ask us, what to do and when. So how often would you suggest that we get an MRI done in patients with progressive MS and those who have relapsing remitting MS? How often should we get MRI done?
Madam, during the diagnosis, at first, whenever they have a symptom and the MS is suspected, one MRI is necessary. So usually we do a full MRI with contrast and screen of spine, so that we define the disease and diagnose the disease. If patient is, because we are a economic country, so we have to go in an economic way. By protocol, every 6 months and 2 years, they should be done. So, but in India, what we follow, if patient is completely asymptomatic, then usually first MRI we do at 2 years. If patient develops any new symptoms, which is not infection, and we are expecting a relapse, then we usually do a MRI just to define, okay, that it has relapsed. Again, it helps us to classify the disease also, whether it is a primary progressive or it is relapsing remitting MS. When patient is on medicine, then every 2 years usually is required if some fluctuations are going on. But as all of us know, it is such an unpredictable disease that patient may have only one episode in life, and for next 10-20 years, they will not have anything. But by and large, if the disease is silent for 5 years, usually the chance of relapses go down.
Thank you, sir.
Ma'am, someone has asked urge to urination and mind, whether some yoga and bladder training exercises help for frequency of urine and urge to incontinence per se.
So yes and no. They do help in a condition which is commonly called as overactive bladder. So overactive bladder, as the name suggests, is a bladder which is doing more work than what it should. Like how we have overactive children, we have overactive bladder. But overactive bladder is seen in people who are neurologically completely normal and seen in people who may have a neurological condition such as multiple sclerosis. So inhibiting the urge is not that much of a solution for MS, because that is the problem with MS. The fact is that the information doesn't reach the brain, and what the brain tells the bladder may also not reach the bladder. So just as I may want to, if I am a patient of MS, I may want to inhibit my urge to urinate, but that signal will not reach the brain may not process it, and it may not reach the bladder. So as a result, patients land up being in a very awkward situation where they think they're trying to hold their urine, but unfortunately they are not. Whereas those who may have a very mild form of MS, but may actually have an overactive bladder as the predominant symptom, but they're otherwise neurologically not so badly affected, yes, in that patient group, inhibiting the urge is in fact a part of treatment. And I'll tell you how it works. So when I inhibit the urge to urinate, I contract the pelvic floor. In one of my slides, I had mentioned that pelvic floor treatment, especially with the help of physiotherapy, is extremely useful. So how do we do that physiotherapy? So we train the patient to contract the pelvic floor. And when the pelvic floor contracts, the brain gets the signal that now the door of urinary bladder is shut. So if the bladder has already started giving a signal to urinate, that signal gets aborted. It's like an electrical circuit, and that circuit gets a break. And as a result, the urge gets inhibited, and the patients can actually prevent the onset of leak. One of the techniques to do that, not just to contract the pelvic floor, but please don't run to the washroom. You know, it's very difficult to contract the pelvic floor and try and run. You can't have a contracted pelvic floor and you can't be running or even walking fast. So the first thing to do if you get a severe urge to urinate, sit down wherever you can and just try and take your attention away from the bladder and of course tighten the muscle in the motion area. I reiterate, the muscle in the motion area, and that in fact contracts the entire pelvic floor, and that helps indirectly in closing the door of the urinary bladder, and that gives a signal to the brain to break the circuit. So this we train all our normal non-neurogenic overactive bladder patients, but very mild MS cases can also be benefited by this technique. So stop doing whatever you're doing. Don't run to the washroom. Sit down, contract the pelvic floor, take a deep breath, and try and divert your attention away from the urinary bladder. These tactics will definitely help if you don't have a very severe form of MS, or if you are a non-MS but are suffering from overactive bladder.
I think questions are over. Any comments, madam, if you want to add something, or Dr. Priyanka, if you want to add something, we can.
So the only comment I can add is that don't accept any form of incontinence due to any cause as something that you have to put up with. Nobody has to put up with that. And don't assume that, oh my God, going to a specialist and going to the surgeon in particular would mean some fancy surgery, expensive medication, fancy gadgetry. See, the whole thing in India revolves around the expenditure involved. And trust me, things are very different. The medications are not that expensive. The remedies are simpler. And surgery, in fact, almost never features in the management of MS with urinary incontinence. So don't shy away from talking about it, because unless you talk about it, your caregiver or family or your treating doctor will not know how severe the condition is. So the first responsibility is to talk about it, because urinary complaints remain hidden under wraps inside your underclothes. And if you're not leaking, but you're just struggling to empty, unless you talk about it, others also will not smell you from a distance. So talk about it, and I'm sure there will be help available. That would be my message to anybody and everybody.
And early treatment always is cheaper and best.
Always.
If we try
Always, always. And also, I think, as my father, who's a very senior urologist, he always says that, Anita, the best in the long run is always the cheapest. Sometimes we do some, non-specific remedies here and there, go to somebody who may be a quack with the help, with the hope that something will emerge out of it, because we assume and believe that a lot of doctors will be expensive, their modalities will be expensive, there will be every step we are thinking of expense. But actually, if you hit, or rather if you approach the correct doctor right at the beginning, in the long run, that would be the cheapest. And so please talk about it and go to the correct specialist. Everything else will fall into place.
And options are always available.
Good evening, ma'am. Ma'am, I have a question.
Yes.
Hello. Yeah, ma'am, I need to know what are the exercises to control your urinary incontinence.
Okay, so very simple exercise, which you can also find on Google. It's called a Kegel exercise. Kegel being the person who popularized these exercises, but basically these are pelvic floor exercises. And in that, the patient is taught how to contract the pelvic floor muscle by focusing the attention on the anal opening, or the opening from where we pass our motion. Concentrate your attention on that and tighten and pull that opening upwards. How do you do that? Imagine you're getting a loose motion, somebody else is in the washroom, and you have to hold your motion. What will you do? You will tighten that muscle. So tighten that muscle and hold it tightened or contracted for a full 5-second period. And then relax the same muscle for 10 seconds. One exercise consists of tightening for 5 seconds and relaxing for 10 seconds. This simple exercise is to be repeated 10 times, which becomes one session of the exercise. I advise my patients to do one session in the morning, one in the afternoon, one in the evening, and one at night. Each session takes only 2.5 minutes. So if you did it 4 times, it will take only 10 minutes. A day has 24 hours. So in the day, you have 23 hours and 50 minutes to do all other activities. So I don't like it if my patients say they don't have the time. There is a lot of time. And many of my non-MS patients, they spend a long time in parlors, in hotels, in doing beauty treatments, and all of these require 4 and 5 hours of your time. I'm sure we all can give 10 minutes of our time to the pelvic floor. And I would go one step ahead and say that if all the girls are taught how to do this during their teenage years as a part of sex education, all these specialists dealing with urinary incontinence will become defunct. And I mean it because pelvic floor exercise is really, really not taught properly. It is never told to the patients. Very often a printed leaflet is given. How can a patient read a printed leaflet and learn an exercise? By that logic, you should never have to go to a gym. Just read a book and you will be expert at doing all the exercises. No, you need somebody to teach you correctly. So again, going back to the same thing, visit a correct specialist, which could be a physician, a gynecologist, a physiotherapist, a coloproctologist, and of course a urologist. They all will teach you the correct technique of doing pelvic floor exercises. Learn it correctly, master it well, and that will go a long way in helping any form of urinary incontinence, at least partly. Most patients will get 50% benefit by simply doing correct pelvic floor exercises.
In fact, this is
Please go ahead. Please go ahead.
very common problem in elderly females,
Yes.
as you said, madam.
Yes, very common. Yes, Dr. Bhatkande. Yes.
Yeah. Is it contraindicated in people with partial uterine prolapse or, pelvic floor descent?
Not really,
Is it
not really,
contraindicated?
provided the patient is aware of the prolapse, knows how to reposition the prolapse, and then is taught the correct muscle contraction. But patients who have a fairly large degree of uterine prolapse, I'm just answering the question, though it's outside the purview of MS, those who have a large uterine prolapse, part of the problem is poor pelvic floor muscle, isn't it? So these people, in fact, are unable to contract their pelvic floor. So in fact, it's exceedingly difficult to teach them how to contract the pelvic floor. More so if they're elderly, it's really not easy for an elderly lady to reposit the prolapse and then to contract the muscle which is already weak. But this is where good physiotherapist comes in the picture. They have gadgets which can electrically stimulate the pelvic floor. They also have very nice biofeedback softwares. So biofeedback can tell us if we are contracting the correct muscle with the help of an auditory or a visual clue. And pelvic organ prolapse can be handled from symptomatic relief point of view quite significantly by correctly performed pelvic floor therapy. Of course, you know, and I know beyond the limit, surgery is the solution in such situations.
So one of the questions had been asked. One of the very early questions in the chat box was actually to do with exercises and prolapse. That's why I asked it.
Right. I may have missed that. I'm so sorry. I'm so sorry. Yeah.
I would like to say that so the symptoms of optic neuritis are more often than not quite glaring, and the only time they are neglected is because if they are occurring only in one eye, the patient may not be aware that he has some amount of vision loss. So if you do experience even slight disturbance, I would suggest the patients to just check your vision monoocularly and ensure that there is no visual loss that the patient is experiencing. If there is some amount of vision loss that the patient is experiencing, and if it is part of an attack, of course we can treat it. But however, if it is a residual disability that the patient is living with, as we often say that treat sometimes but comfort always. So we have a lot of ways in which we can visually rehabilitate the patient, help them navigate around their surroundings. If the visual loss is concerning the upper part of the visual field, we explain the patient how to look at the objects around them. If it is involving the lower part, there are different ways of it being done. If there is double vision, as I said, there are different options that we can do. And I'm sure that there is some solution to your problems. And as ma'am has correctly said, you just need to come forward and go to the right specialist, and I'm sure help will be there for you.
Yeah, in short, don't ignore any vision loss. We plan to investigate and go accordingly. Yeah.
Yes.
Thank you. Thank you. Over to Dr. Bhatkande, madam.
So would you like to sum up in 2 lines, 2 words? Would you like to sum up?
As we know that MS is such an unpredictable disease. Someone can have a very mild symptom, single attack, and someone can have a very severe attack. So whole discussion was, if you have a symptom, please visit a doctor, get your diagnosis correct, and start treatment accordingly. If you have any symptom specific to an organ, say eye or urinary or bladder, then why the problem is happening, we should investigate, and then the plan becomes easy. So please talk about your symptoms. Please visit doctor, tell them your symptoms, whatever odd they may be. Always we like to find out the solution and help our MS patients. Our MSSI Society, means Mumbai chapter, we are very active. In fact, many times we organize our camps, we try to solve these problems, and Anita madam, Dr. Priyanka will be helping in future. So all of us try to help in whatever ways we can. So please openly talk about it and discuss with the appropriate doctor. Thank you, madam.
Thank you so much, everybody. I'm just taking a minute to acknowledge Sheila Tai, who has just appeared in one of the windows. And I have immense regard for Sheila Chitneshji, because she has been a pioneer in taking this society further. And she's so very reachable and always available. So thank you so much, Sheila Tai, for always asking me to take part in all your activities. I consider this as a privilege and an honor. Thank you so much.
Dr. Anita, you are so precious to me. You have never said no to me. That's the biggest achievement for me, probably. because always available and so nicely, Anita, you always say. So, I mean, it was wonderfully educative
Thank you.
session.
You're very
For
kind.
me
Thank you
also.
so much.
Always it is useful to me also. Thank you so much. And thank you, Dr. Priyanka also, because first time, and she's such a young one, just a new doctor. So she's done also well, no, Dr. Singh? And Dr.
Yes.
Singh,
Yes, ma'am.
immense thankfully to you because you agreed and you did it so well. And another thing is that you talk Marathi, which was the new knowledge to me. So thank you very much. आपली भाषा असेल की जास्त छान वाटते.
Wonderful team, two of you. It is a perfect team for MS session, you know. I think it was really, really impressive, Dr. Patel and of course Dr. Priyanka also and Dr. Singh.
All three
Yes,
were
I'm so happy to have so many people thank everybody, but I think it's something that we need to do officially. So I would like to thank our founder, Sheila Chitnis, for being the, she was actually the entire, this entire webinar, and in fact, our series of webinar have been powered by her. So Sheila, thank you so much for that. And Vikasha, it was lovely having you talk about introducing, MS International Federation, then Indian Society of the Multiple Sclerosis Society of India, and of course, telling us about the World MS Day and the significance of that. And of course, the three speakers were absolutely wonderful. I mean, if I can call you all gorgeous people, then I'll do that. Okay. But thank you, Dr. AK Singh, for coordinating this very nice and lively and interactive session. Thank you, Dr. Anita Patel, who's always been our go-to urologist where MSSI Mumbai chapter is concerned. And thank you, Priyanka. It was wonderful being introduced to you. And I'm sure you're going to be a part of our MS family. So thank you so much for your inputs. I'd like to thank our tech team, our backroom team, Javed and Geeta and Neetu, and I don't know, Javed, if Kritika has also helped you out here. Thank you so much to everybody. And of course, I have to thank our sponsors who were very keen that we at MSSI, we spread the awareness about multiple sclerosis, not only amongst the MSPs, but also amongst their caregivers, amongst doctors. So thank you so much, Sanofi, for hosting this entire series of webinars. I would thank you, and this has been a wonderful session. Thank you, everyone. The audience was the best. We've had so many people, and even at the end of the session, we still have people beyond the 50 mark. So that's wonderful. And thank you, everybody.
No,
Rekha, thank you very much, because your Thanksgiving was also wonderful. You remembered each and everyone. Thank you so much, Rekha.
Before closing the event, may I request you all to kindly switch on your camera so that we could take a group photograph.
Okay. Right, David. Thank you so much. And I think we can close down now.
Thank you. Thank you so much.
Thanks to everyone. Thank you to everyone who joined in. It was wonderful. I saw a message from Sandeep. So I must say, Sandeep, thank you for joining us. And, what a wonderful message you gave our speakers. Thank you so much for that. Sandeep is our honorary secretary. National
Thank you so much.
Yeah. Okay. David, you may close the session, please.
Yeah, thank you very much.
Thank you.